Good afternoon and welcome to all of you that have joined this webinar. This is the second of a series of webinars taking place, being done by the East of England Local Safeguarding Adults Board, learning from local boards. And as I say, this is the second of a series that are taking place over the coming months. This one has been arranged and is looking at some issues that have been presented by the Luton SAB board. My name is Brian Boxall. I don't actually work for the SAB board, but I am the author of the review that we're going to oversee in a minute. Colleague Teresa Kippax is going to join us and present later on after I presented the initial review. She's the CQC National Safeguarding Advisor, and she's going to start to consider some issues around the role of CQC and the local authority in the inspection of care homes. But first of all, I will start to present, if I get the right, present a SAR that was presented by Luton SAB and commissioned by Luton SAB and was undertaken by myself. Once we've presented this and Teresa's done her slot at the end of it, we'll ask for questions, which is a strange environment for me because I'm used to seeing people, but I can't actually see anybody. So it's forgive me if I stumble slightly. This review was commissioned by Luton Safeguarding Board, and the background of the review was it was involving a Mr. B, who was an 87-year-old male, had been known to social care since 2014. In 2016 became a community case for the community service, local community services for catheter care. In May 2017 received a diagnosis of end-of-stage kidney disease, which actually meant that he had between 3 and 12 months to live and went into palliative care and end-of-life care. On the 23rd of February, several months later, 2018, he commenced respite at an authorised care home. Less than a month later, a GP arranged an emergency hospital admission from the care home, and unfortunately the following day Mr. B died. As a result of that, the ambulance service, local ambulance service, submitted a safeguarding concern, which noted tears to skin, multiple bruising, different colours, indicating injuries at different times, and that Mrs. B, Mr. B's wife, had told them that he had fallen out of bed. None of the incidents have been witnessed or reported to the health or safeguarding. This kicked off a Section 42 inquiry after his death, which concluded that Mr. B suffered neglect and acts of omissions whilst in the care home. And in May 2018, a CQC inspection found the care home itself to be inadequate. This is a very sad case about an individual who was at his near the end of life that should have been receiving good care in a dignified way, and as will be seen, that didn't occur. And the review really examined 3 areas: the care and support provided to Mr. and Mrs. B whilst in the community, response to care provided to Mr. B whilst he was resident of the care home, and thirdly, the Local Authority and Quality Care Commission's quality assurance processes. What I'm going to look at is, whilst this seminar is about quality of care home, I am going to touch a little bit on the palliative care, just because there's some lessons to be learned from the palliative care. Palliative care was quite a big chunk of the report, and the idea is to actually offer dignity while dying. And I use the NICE guidelines to guide me through what should be taking place. But there's some headlines that I wanted to highlight to you. But Mrs. B was an individual who had looked after her husband for many years and given him love and care. And she was struggling to understand what was being offered when the palliative care end-of-life care came. There was a number of agencies that were involved, quite rightly: social care, district nursing, community care, and Macmillan nursing as well. So there was some good support, but it was becoming quite confusing for her, and she was a bit confused as to what was being offered. Because there were separate visits that led to confusion and duplication of effort, information. And she made comments like there was too many cooks. She's been spoken to since, and she made comments like there was too many cooks. Highlighted from the IMRs, the GP highlighted it was unclear whether Mrs. B actually understood the do not resuscitate, attempted resuscitate. She wasn't sure what the gold framework was, and the gold standard. She was expecting something and was very disappointed when she didn't get things. So she was very confused as to what she was actually expecting to receive, and it's made it difficult for her. Confusion is understandable, because you can imagine how upsetting receiving the news that the husband was facing the end of life in the coming years, and how upsetting that must have been. She'd been his main carer for many years, and this was life-changing, and there had to be a good level of communication support, so both Mr. and Mrs. B fully understand what was happening, and who was going to support Mrs. B and her needs, and who she could contact out of hours. The other thing that was quite noticeable was the way that people provide information. In references, the word dying wasn't used very often. And in fact, that caused a problem, because they used words like deteriorating and poorly health, instead of being upfront and Mrs. B being fully aware that he was dying, because she may have made different decisions if she'd have been fully aware that he was as bad as he was. Supporting workers also didn't have a good understanding of the process. The end of life process it's a very specialist area of work and needs some very specialist understanding. And it was quite clear that there was a lack of understanding of the gold standard framework. There was a lack of understanding about the continuing health fund care, especially the fast funding. And there was a lack of understanding of end of life care and what was required. And the biggest thing that actually was missing from all of this, including when he went into the care home, it was Mr. B's voice. There was limited evidence that his voice was being heard. There was descriptions of his condition, but very little recording about what actually he wanted and what he desired. Visits were arranged when he wasn't present. Mrs. B would make arrangements when he wasn't present. He was attending a day centre, so some decisions were being made when he wasn't present. There was no mental capacity assessments, and there was conflicting recorded observations about what he actually did understand, because in some entries it gives indications that he did understand what was taking place, and others it didn't understand. So there was a need to be continuing assessments being continued throughout his treatment and understanding. And the one thing that did come across was that Mrs. B had a lasting power of attorney, which was good and was in place. But that was never challenged in terms of, because there was no mental capacity of his assessment, that was never challenged, and decisions were being made, and it was unclear whether actually, while she was a loving wife and was looking after him, whether some of the decisions were being made in the best interest. That was never challenged or tested, and there was a lack of people's understanding of a lasting power of attorney. It was just she was making decisions on his behalf, and that was accepted. And my conclusion was the lack of Mr. B's voice was significant. Decisions at this stage in his life were essential, as it could have been informed his palliative care plan. How Mr. B wanted to be cared for is not known, including his views on respite. And that's important because he was being put into respite care. In January 2018, the social worker completed a needs assessment. Earlier on in the previous year, it was quite clear that Mrs. B also needed some support, and she had some health health issues that she needed to look after herself, and she couldn't cope with Mr. B at the same time. So there was a needs assessment completely started in earlier September, October 2017. But it was clear at that stage that Mr. B wouldn't attend respite. He wouldn't go into respite. Again, there's no clear evidence of that. That was what's being suggested. So she wouldn't let him go into respite at that stage. But by January 2018, she was desperate and needed to have the treatment that she needed. So they completed a needs assessment. The assessment did not include any evidence of lack of capacity. Again, it was a matter of lack of evidence of capacity. So how was he making the decision? And there was an assumption all the time that he agreed to respite, or that his wife was able to make the decisions on his behalf. When I spoke to Mrs. B afterwards, she was very clear that he would never have agreed to go into respite. Despite what was being written, he would never have agreed, which brings into question as to whether or not he actively was aware of what was going on, or was aware of the decisions that were being made. So again, the lack of his voice, which goes throughout this report. So again, my conclusion was care home respite was the option progressed. Given that there seems to be evidence that Mr. B had not agreed to this placement, other options should have been considered. And what wasn't being considered was providing more care at home so that Mrs. B could have her treatment. That wasn't being considered. The respite was the agreed condition, and that's where he ended up. The transfer of care. By the stage that he transferred care, he was supposed to go into respite for 2 weeks in February 2018, but his condition was starting to deteriorate several weeks before then, including more aggressive behaviour and difficult behaviour. His behaviour was becoming erratic and challenging to some extent, and the suitability of the chosen care home to have the skills to be able to care him should have been reviewed, especially in the light of the known concerns. But there was no questioning of that. There was no revisiting of the assessment. And what is quite clear is that there was a lack of coordination handover between the care home and the supporting agencies. So whilst this care home was a specialist in dementia care, it was unclear whether they actually fully understood how difficult that it was going to be to undertake care for Mr. B. And the transfer itself was distressing for Mr. B. He was actually taken, he attended a day centre several days a week, and he attended the day centre and was taken directly from the day centre to the care home without his wife. And it's quite clear that he was very distressed about it, and he was very aggressive when he turned up at the care home. So, and as I said to you before, it is very unclear as to whether he knew he was ever going to the care home, and he clearly didn't want to be there, because the first phone call that evening from his wife, he said, "Why have you put me in here?" So I think there's questions as to whether or not there was a doles issue here. And again, the paperwork makes it very unclear. So Mr. B, who should have been having caring, loving last few months of his life, was put into a situation that was distressing him even more, and probably led to some of his difficult behaviours. Now, he turned up on the 23rd of February 2018, and within a few hours at 4 a.m. in the morning, he was found he'd fallen out of bed onto the floor. Mrs. B, his wife, raised issues with the GP, district nurse and social worker within days, and kept raising them. Now, Mrs. B had been used to looking after her husband in a caring environment with the district nurses attending. She assumed that actually that would take place when she went to the care home, because the district nurse was still going to attend as per the arrangement for the community. But within days, she had grave concerns, and she was starting to raise them. And she also had a background in care homes, so she knew what good care looked like, so she should have been listened to. And the issues she was raising included falls on a number of occasions, all unwitnessed. He fell several times over the 2 or 3 weeks he was there, all unwitnessed. Unexplained injuries, catheter care, dirty personal care, poor care including food issues, inappropriate clothing, and he's still in his bed at lunchtime, and medication errors. So there was a significant number being reported very early on in his care. And I looked at what the response was to that, and the visits were being undertaken by district nurses. In the 20 days he was in the care home, there was 10 visits by the district nurses, although they were different nurses, so there was no continuity of personnel. And they were responding to his immediate healthcare needs, such as catheter care needs and some bandaging and other issues that they were looking at. But they didn't consider or take into account the overall standard of care that was being provided, despite what Mrs. B was raising to them. And also the difficulty they had was that the nurses were not failing to record reported incidents such as falls, skin tears on the Trust's incident reporting systems. So the incidents never got linked. They never got linked together. So they were being dealt with all the time as individual issues. They weren't being dealt with as a series of care issues. The social worker did contact the care home manager and was given an explanation as to the concerns that Mrs. B was raising, and most of them were around Mr. B's difficult presentations and how aggressive he could be. And the social worker accepted the explanation given, and the one thing that is very clear is they never visited Mr. B at the care home. So they were being informed regularly by Mrs. B that she had concerns. They contacted the care manager and accepted the explanation that was being given and never visited Mr. B at the care home. And what also took place was there was a lack of joint visits or professional meetings to consider the concerns. By this time, the GP, the district nursing, community care and the social workers were all aware of Mrs. B's concerns, but there was no joint visits or professional meetings to consider the concerns. And one of the IMRs, I think this hits the nail on the head. There was evidence of lack of professional curiosity around causes of incidents. The focus was on an efficient completion of a series of physical care tasks rather than maintaining an inquisitive mind about incidents and their significance, reporting them through the appropriate formal challenge channels and acting as Mr. B's and Mrs. B's wife's advocate. And I think this is what becomes clear, is that people were doing tasks. They weren't considering the overall standard of the care home. They were looking at the individual and the task of the individual, and they were also accepting that his behaviour was adding to the concerns, whereas they should have been looking at, he was a dying man. He was clearly dying. He was clearly deteriorating in his health, and they weren't looking at how to allow him to die with dignity. And the one thing that actually was quite surprising, given the level of concerns, at no time was a safeguarding concern raised. So there was no opportunity for an inquiry to commence into particularly Mr. B's care. And I think I found that this issue was also highlighted in the serious case review concerning the Western Rise residential home, where it says the key issue is a widespread culture of acceptance, accepting the situation in a home without probing further or challenging, that acceptance occurred within the staff employed within the home and within the healthcare staff that visited. Policies, procedures and regulatory systems should identify incompetence, poor practice and poor management. However, when the system is under pressure, when staff feel that there is nowhere else to place difficult residents, then issues that might in another context trigger an alert may not do so. When staff of all kinds see others accepting poor standards, then their own willingness to challenge can be blunted. Standards can deteriorate until somebody calls a halt, and it's normally somebody calling a halt because there is some significant injury or in this case death to Mr. B. And I think this is a concern that's been raised in several serious case reviews around care homes, is that because there's pressure on the system, and this really applies to the COVID even more now, there's pressure on the systems, there's lack of places available, is that there seems to be an acceptance of a lower level of care rather than risk having the home be put under pressure or to close. And I think this is the pressure that needs to be highlighted from this review, is that actually staff need to consider the welfare of the patient or the person they're looking after, and should be looking at good quality care. What does good quality care look like, and be expecting good quality care. There was a time when actually this could have been highlighted, the concerns that were being raised. Mr. B was originally there for 2 weeks. That was the respite period. That needed to be extended, or was going to be extended, and so the social worker requested an extension to the respite. But again, they had failed to visit the care home, so they hadn't looked at the new situation, they hadn't done a new assessment and reassessment, and they hadn't pulled together professional meetings to actually say, is this the best place for them? Because at this time it was very clear that he was very close to dying, and Mrs. B had always wanted for him to die at home. She wasn't, I don't think, fully aware of how close to dying he was. And there was an opportunity here to have actually looked at probably first fast funding, health funding, and to have enabled him to go home and potentially die at home. But again, he wasn't spoken to, he wasn't thought about, and it was just a sort of almost an automatic, we'll have an extra couple of weeks that were agreed, and he stayed a couple of weeks, even though there were serious concerns about his health, and he died within a few days of that decision being made. That really is Mr. B. It's a sad story about an individual who should have been looked after in his dying days, and his wife should have been supported in his dying days, but actually he was put into a situation that made his last few days quite difficult, and was very difficult for his wife, because his wife, actually, having spoken to her a lot, she blames herself for putting him in the care home. She blames herself for his death, and that is several years later. She is still blaming herself and hasn't been able to get over it. And that shouldn't have been the case. He shouldn't be blaming herself. But it's difficult to explain to her that it's not her fault. The second part of the review that I did was that there was clearly some concerns about that individual care home at the time because of what Mrs. B was saying, and there was a lack of safeguarding. The question I asked of the panel, and then looked for evidence, was what actually was known about that particular care home at that particular time, and should it have been actually influencing whether or not Mr. B should have been there. Now, the care home oversight is undertaken by three processes really, but two main processes. The Quality Commission is the regulator responsible for application of enforcement and powers, including closure, and I'll let Teresa go into that a bit more later on. But the local authority, quality assurance or placement team, or the equivalent, whichever you have on your local authorities, oversee context and only take action relevant to contracting of a care home. So I looked at the two, and what I found out was that there was a local authority review QA placement team undertook a review in January 2017 using, at the time, the ADAS work process. This was a annual review. It was graded good, but actually had areas failing, including staffing and safeguarding. So the ADAS book said it was good, but it did have some failing in the area of safeguarding, which was interesting. A remedial action plan was produced and validated in 2017, and what I found was that the action taken was basically to have an action plan in place. What it was never done was never tested as to whether it was implemented or made a difference or was strong enough. But because it was graded as good, it was validated. And as I say, there was lack of the plan was effectively implemented. There was a second review that took place a year later, and this, as you will see in a minute, was kicked off by another Section 42 that was taking place. this one was done under a slightly different system, the provider assessment and market management solution system, but it was sort of parallel to the ADAS system as well, because the systems hadn't changed over. And it found that some of the areas of concern that were identified in the area, all the areas of concern that were identified in 2017 still existed. And not only was in the PAM system, there was 12 of the 16 standards that required improvement, including issues around mental capacity, organisational culture, safeguarding reporting and safeguarding medication. And they were just 4 of the areas that were highlighted. Which indicates to me, or was starting to indicate to me, that despite the review in 2017, despite the action plan that should have actually improved things had actually deteriorated within the home. And this was evidenced, the lack of improvement was evidenced in the Care Quality Commission in May 2018 inspection, which was highly critical of all areas, including those identified as early as 2018 review. And that was done in May 2018. And this was the CQC findings. People experience was poor living at X. There have been substantiated concerns from the local authority about neglects and acts of omission. The people we spoke to did not speak very positively about the service. We had concerns about people who were not always safe, who were there at risk of falls, those who were an unhealthy weight and those who needed certain medicines. Staff did not always respond to safeguarding concerns in a safe way. People's dignity and comfort was not always promoted. Staff did not engage with people in a way which demonstrated they knew the people that they were looking after. And I think if you look at what Mrs. B was actually complaining about, this is set out in this, which is several months later. At the same time that the reviews were taking place, there was also some Section 42 inquiries that were taking place into issues raised at the care home. One as early as December 2017 was Section 42 concerned raised about the home, and that was concluded in 2018 and also substantiated neglect and acts of omission. 6th of March 2017, a further Section 42 commenced. This was in respect of a serious injury. And then we got in May, after his death, Mr. B's Section 42 commenced. So you can see that what I was finding from the review was that actually there was some growing concerns that had been obviously highlighted as early as December 2017, January 2018. Yet, when decisions were made about Mr. B as to whether to place him, they are not evidenced anywhere in any of the assessments that were taking place as to whether that was a suitable location. And this really highlights this as you look at the case chronology. The 2017 local authority review of home with the failings identified. December, the concerns raised about the home through the serious injuries. The review with, again, more failing areas identified. And then you had Mr. B enter the home on the 23rd of February, so the concerns about the home were known, and Mrs. B raised concerns. And in fact, the 6th of March, a further Section 42 was commenced. The 8th of March, the respite extension of Mr. B was requested. Again, the concerns around the home and the concerns raised by Mrs. B were not being highlighted. And then a few days later, Mr. B was taken to hospital and unfortunately died. And I put that down there to highlight that actually what wasn't being thought about was the intelligence loop that actually meant that when considering social worker or anybody considering placing somebody into a particular home, as to what's known about that home, what's the background of that home. So the assessment should actually include background of the home, because then serious questions could be raised as to whether that was the best place for him, given the fact that he was clearly failing in areas that were identified by Mrs. B. And then it led to the CQC inspection, which was led to inadequate. And really, what I've concluded that it should be safeguarding assurance loop, which ensures that regular quality assurance safeguarding info continually passed as Care Quality Commission, Care and Support and Commissioner. Safeguarding concerns raised, quality assurance, care placement provides background information for investigations, and outcomes in investigation inform future monitoring plans with the provider. And I would also add to that is that also ought to be available to those that are actually looking into the care home in terms of social workers that are looking into the care homes, because I think there's serious concerns about the length of time it took. Bearing in mind that the January was when the issues were highlighted. The care home obfuscated for several weeks, challenging the findings, put into a plan together, and it wasn't until May 2018 when the CQC brought their inspection forward. It was supposed to be June, brought their inspection forward, that actually they were action was able to be taken. And what wasn't taken into consideration around all of this was the care of the other patient, the other residents within the home. That really is about the care home, and Teresa will talk about the restricted role of the local authority and the role of the CQC. The other thing that I want to just highlight is around criminal investigations. It is quite clear that the police got involved very early on in December 2017, January 2018, when there was a specific injury, a serious injury that was taking place. And they were involved with the Section 42 and concluded that there wasn't sufficient evidence. Reviews I've done of some other investigations shows that police are very good and get very involved when there is a specific offence, like an assault or theft or fraud or something like that. But what there is the offence of the Courts and Criminal Justice Act 2015, which talks about ill treatment or willful neglect of patients by care worker or care providers. So you can actually look at individuals or the provider themselves around people with limited mental health capacity. But in this case, in Section 42, in this case, is that Mr. B's Section 42 was kicked off in May 2018. The police weren't informed or weren't involved until May 2019. And the concern is by that time, records, evidence, staffing that they could interview and evidence is not available. So it makes it very difficult to make any cases. These are difficult cases to prove in the first place. So I think when you've got a series of Section 42 inquiries and you've got a failing care home, and then the police should have been involved a lot earlier, and the police should be involved in earlier. But the issue with this is that officers that are going to look at willful neglect of patients need to do one or two things. They have to have a good investigative knowledge, and many of these officers are very good investigators, but they need support from care professionals to prove the case, because there's a lot of evidence involved. And all I would say is that I think with Section 42s, very often the police have got a tendency to wait for the other agencies to provide the evidence, whereas actually, in my view, and I'm an ex-police officer, so they should be leading as to what evidence they require and to support their case, and probably working with the CPS as well. But that was an extra issue that came out of that. Really, I'm coming on to sort of the learnings of the review now. The need for coordination of palliative care between support agencies to ensure there's a clear care plan in place. The advanced planning didn't really take place. There wasn't a clear plan and coordinated plan between the agencies. And it should be to review of circumstances such as deteriorating health changes in the care provision, because he did deteriorate an awful lot. And I think a lot of people were actually excusing the care home on the basis that he was a difficult patient, but he was a dying patient. The voice of the individual subject to the care provision must be heard. This should be clearly recorded, and where necessary, there should be in place mental capacity, act to evidence capacity. This is an issue that comes up on almost every SAR, and really there is a need to really look at legal literacy around mental capacity. And a clear understanding and a good recording of mental capacity. There seems to be an exception that people don't have to record it if there is capacity, but I think evidence of capacity should equally be recorded at times. Where lack of capacity evidence, the use of accuracy should be considered to demonstrate the decision will be made in their best interest. As I say, Mrs. B was making decisions, she was being accepted to make decisions, but without the capacity, mental capacity evidence, were they in his best interest, and should they have been challenged? That's the lasting power of attorney in the court of protection. Serious reported concerns about the level of care being provided in the care facility must be responded to positively by visiting the facility and assessing the concerns and suitability of the care home. If considered unsafe, then a safeguarding referral should be made. As I said before, the social worker himself never visited the care home, and there was plenty of evidence that should have actually led to a referral. Doesn't mean to say that the Section 42 would have taken place, but at least a referral would have gone in. Evidence from different sources that a care provider is failing, especially in the safeguarding domain, should be responded to in a timely way, ensuring the involvement of the Care Quality Commission, and Teresa will talk about that in a minute. There is a need to check that actions have been completed and they continue to be applied over a reasonable period of time. I think there is an assumption that a care home produces an action plan, but actually there needs to be a longer time to actually say is the action plan being effective? Is it being implemented? And then, as I finally identified, early police involvement in inquiries is important to ensure secure potential evidence. Again, it's like a murder. If you don't have the golden hour of a murder, you lose evidence. And this is the same with this, is that actually people die in care homes. There is an assumption that it's due to their health, and in Mr. B's case, there's no suggestion that anything could have happened would have stopped him dying. But one never knows until one looks at the evidence. I think that's enough from me. I think we're going to go over to Teresa now, and then we'll have some questions at the end of it. Thank you very much for your patience and forbearance. I'll just stop sharing, Teresa, and then you can.
Okay. Thank you. Howard, could you share my presentation, please? Thank you. So we'll start in just a minute. I'm going to turn my video off. I seem to have some kind of echo, and it might be to do with my signal. So I'm just going to turn my video off, and then I'll turn it back on in a wee while after I finish my presentation.
I'll get your slides as quickly as I can, Teresa.
Okay, Howard, no worries. It's very odd. Can I just say it's really odd, like Brian, not being able to see anyone who's on the call. It's an odd situation, actually. I'm used to seeing people's faces, so it's yeah, it's a bit strange talking to the ether. So I'm just going to turn my video off. Thank you, and then you can concentrate on the slides rather than my face. Thank you. So thank you for inviting me along today. I think this has been a long road with this SAR. It's been going on for quite some time. I'm really pleased to be here, and I just want to take you through a few things about CQC's role in safeguarding, what we do, what we don't do, and I want to talk and concentrate a bit more actually on the way forward and what we've done in the last 18 months, because we've completely shifted how we regulate health and social care provision. So if you could move on to slide 2, please, Howard. Thank you. So CQC have been involved in over 40 safeguarding adult review or learning reviews during the last 4 years, and I coordinate our involvement in them. Therefore, I have a national oversight of the findings and sort of bringing those together for us as an organisation. There's some common themes that have emerged. Organisations being clear about their role, both us and others, sharing of information in a timely way, and confusion sometimes about what should be shared and with who. The responsibilities and functions of commissioners and of us as regulator, our messaging about our role as regulator of health and social care provision and what it is and what it isn't. Our clarity about our powers and what we can and can't do. Providers not adhering to the regulations that actually govern them, that CQC are reliant on partner organisations telling us that providers are not providing safe care, that commissioners share what they are finding. We don't know what we don't know. CQC being very clear about what action they are taking and why, and what they can't do, and sharing that information with partner organisations in a timely way. fulfilling the requirements around safeguarding, and who is responsible for action. Our role in safeguarding, our overall objective, is to ensure that providers of regulated health and social care services provide safe, good quality care and treatment that does not expose people to the risk of abuse, improper treatment and neglect, and protect them from harm. We do this in a number of ways. We set out requirements for registration within our regulations. We assess whether a new service provider will meet these regulations and determine whether to register it or not. When we're registering an existing provider who wants to add something new, they're subject to the same scrutiny. The regulations include our expectations of how providers will carry on high quality regulated activities with effective safeguarding policies and systems in place to protect people using the service. We monitor providers by obtaining, assessing and reporting on information and data obtained through multiple sources, and we use this information to assess any risks posed to people. We identify those services where there may be an increased risk of harm due to their specific nature. For example, where people live or stay long-term in regulated services, where the service is not well led, where staff do not have the right training, skills and experience to support people, and where the culture does not support positive and open engagement between staff and people using services and their families. And I think that's been apparent in this particular SAR. Once we have identified risks, we will take action to protect people who may be harmed or where there is a breach of regulations. We publish our findings about safeguarding within our inspection reports, and we give services a rating for each key question, which will reflect our findings about safeguarding and the quality of the care. We require all providers, as appropriate to the service, to follow the arrangements set out locally to enable them to report safeguarding incidents in line with current national legislation. We hold providers to account by taking regulatory action to ensure that they rectify any shortfalls in their arrangements to safeguard people and that they maintain improvements. This includes requiring providers to produce action plans and taking enforcement action to address breaches of regulations. We work with national partner organisations to influence the strategic direction on safeguarding, advising and supporting developments and undertaking independent thematic reviews on areas of health and social care where systemic concerns have been identified. We ensure that all providers have evidence that their staff are trained and competent in safeguarding children and adults in line with national good practice. We act where providers fail to protect people using their service or fail to report abuse caused by others. We use our enforcement powers to hold providers to account for failures in protecting people from abuse and take appropriate enforcement action. We engage with safeguarding boards and commissioners of health and social care services to respond to or escalate concerns so that we can work together to safeguard people. We monitor whether registered persons and other professionals promote awareness of the Mental Capacity Act and are aware of their own responsibilities under it. We monitor use of the MCA and DOLS in all care homes and hospitals in England and report on this annually. We require providers to tell us about specific incidents through a statutory notification process, including abuse, deaths of people using their service, involvement of the police, and serious injury. Our approach to assessing safeguarding practice within providers considers the systems and processes within each of the 4 key questions: safe, effective, caring. Sorry, 5 key questions: safe, effective, caring, responsive, and well led. We look for evidence of good governance and oversight from senior leadership and expect to see that providers learn lessons from safeguarding incidents. Our approach and what we do, where we find poor care or treatment in a service, for example, as a result of evidence or breaches of a regulation, if we determine that there is no serious or significant harm to a person, we will not make a safeguarding referral to the local authority. However, we may share concerns with the local authority's contracts or quality team. We will assess the risk to people using the service of any concerns about the care and treatment being provided, and we will take appropriate regulatory action to mitigate those risks. We will engage with system partners about issues in the quality of care, and we will speak with the provider. Although we may not raise a safeguarding alert to the local authority in these circumstances, we may share concerns with them. We will make a safeguarding referral, including from unregistered services, to the local authority if we believe abuse or neglect is occurring, or there is a risk of serious or significant harm to a person or people, and we are the first organisation to become aware of this information, for example, during an inspection or through our monitoring process. We will use our own internal decision-making tool to determine whether to make a referral, and we will also contact the police if we suspect a crime against a person has been committed. We will respond to concerns where we suspect abuse or neglect. We will work where appropriate with colleagues from local authorities and the NHS and clinical commissioning groups or integrated care systems and the police, sometimes in parallel with other investigations or inquiries. Excuse me, just a moment. So I've been doing a lot of talking this week. My voice is going. What we don't do, we do not have a statutory duty to investigate safeguarding concerns. This is the responsibility of the local authority and the police where it is suspected a crime has been committed. We do not routinely attend Section 42 inquiry meetings or multi-agency meetings convened by the local authority when they're making inquiries. However, there are times when it may be necessary to attend, including where there has been a serious incident or failure of care, where one or more service users have been harmed, where the failure has been systemic, where there is a potential breach of regulations, when we are taking or considering taking enforcement action, where there are concerns about institutional abuse where a registered manager or nominated individual are implicated. Our role is not as a decision maker in multi-agency discussions, but to consider the evidence presented to decide on our own regulatory response. Brian has already very adequately set out the learning from this particular SAR. I would like to look forward a little bit, talk about what CQC have done in the last 18 months during what has been a very difficult time for health and social care providers and all stakeholders, in particular CCGs and local authorities who've had to determine their local response, what we have changed and what we're planning. Could you move on to slide 3, please? Thank you. So this is who we are. We're an independent regulator. We only cover England, and our role is to make sure that services are safe and that people are not harmed. Slide 4, please, Howard. Thank you. This is our scope of regulation. As you can see, there's, we regulate over 40,000 services, so we are a bit busy a lot of the time. And we have 3 distinct inspection directorates. We have adult social care, which of course is the predominant sector in the country, hospitals and primary medical services and integrated care. We're very proud to employ a mix of non-clinical and clinical staff, and including social workers and nurses and doctors and paramedics. So we have a wide range of expertise within the organisation. Slide 5, please. Thank you, Howard. COVID presented a major health crisis that required us all to work in very different ways. During the early stages of the pandemic, we moved quickly to adapt how we regulate and work within the system. We wanted to support providers to keep people safe, allowing them to focus on responding to the emergency, avoid our inspectors spreading the virus inadvertently, and reduce demand for scarce personal protective equipment, so we paused our routine inspections. While routine inspections were paused, we never stopped regulating. We continued to inspect in response to risks and concerns, engaging providers and continuing our monitoring activity to support our ongoing assessment of quality and safety, identifying risks to the safety of people and ensuring that human rights were protected by gathering and analysing information, working with providers and partners, acting on what we knew, undertaking focused responsive inspections where there were risks to the public, using our powers to act against those responsible where we found unsafe or poor care. We developed new monitoring tools. This included, for example, our emergency support framework, which supported inspectors to understand where people may be at the greatest risk of unsafe care. It helped us gather information around adult social care, both in care homes and in the domiciliary care sector. We shared our learning probably better than we ever have before. As part of the local system, we improved our coordination and our communication with local and national partners. Slide 6, please. Sorry, my voice is really going. I'm so sorry about this. Can you just excuse me a moment? I need to cough.
I think Teresa might have dropped off.
Yeah, she does seem to have left the call a minute, so, or the meeting. Hopefully she'll be back in a second.
Can I just say something while we're waiting for her to come back again? Just to really reiterate, which I didn't do in the review, is to thank Luton and all the services in Luton for openness around their review that they took place. So Teresa's back, so I'll shut up.
You're on mute, Teresa, still.
Sorry about that. I lost my signal or something, and it just chucked me out. I'm not sure where you heard up to.
I think if you start from this slide again, probably be quite useful.
Is this slide 6? Okay, all right. Okay, right. I'll do it all again. Okay, no worries. Thank you. So the COVID pandemic presented a major health crisis that required all health and care bodies, including us, to work in a very different way. During the early stages of the pandemic, we moved quickly to adapt how we regulate and work within the health and care system. And we wanted to work in a way that was supportive both to providers and also our partner organisations. Whilst we paused routine inspections, we never stopped regulating. We continue to inspect in response to risk and concerns, engaging providers and continuing our monitoring activity to support our ongoing assessment of quality and safety in services. We did this by gathering and analysing information, working with providers and partner organisations collaboratively, acting on what we knew, undertaking focused responsive inspections where there were risks identified, and using our powers to act against those responsible. We captured and shared our findings so we were transparent about the action we were taking. We developed new monitoring tools. For example, this included our emergency support framework, which supported inspectors to understand where people may be at the greatest risk of unsafe care, because of course we had a whole sector which had been closed down. We shared our learning and will continue to do so. I'll talk about that in a little bit, about our insight reports and other reports that we've carried out. Local systems have and continue to have an important role. Sorry, can you move on to the next slide? Sorry. So local systems have and continue to have an important role to play in the work that we have done and to understand how health and social care services are joining up. Our monthly insight reports have shared information during the pandemic. There is a link there. If you go to that link on publications, you'll find a whole raft of documents that we've produced in the last 18 months. Our insight reports reported on each month we gave a particular insight, at first. So there's one about the prevention infection control procedures in place in services. We talked about, how services were joined up, how they were working together. They're really useful reports. They're very easy to read, and I would urge you to have a look at them. So we reported on how care homes managed infection prevention. We were commissioned by government to undertake a thematic review on the use of DNAR CPR during the pandemic. We've also published a number of thematic reports. Beyond Barriers highlighted how people's experience depends on how well services work together with and for them, their families and carers, a theme in this SAR. The pandemic has further demonstrated the benefits of creativity and innovation through collaboration. We continue to conduct provider collaboration reviews. And what we've done so far is we have published, in phase 1, we published a provider collaboration review on care for older people, urgent and emergency care, cancer care services and pathways, services for people who live with a learning disability in the community, and services for people with a mental health condition will be published in the autumn. Slide 8, please. Thank you, Howard. Thank you. So provider collaboration reviews, the speed and scale of the response required by COVID has highlighted how any fragmentation, however small, in our current health and care systems significantly impairs the country's ability to respond. The reviews include understanding the journey for people with and without COVID across health and social care, including the independent sector, as well as council and NHS providers. The objectives of the work are to support providers by sharing learning and how providers are preparing to re-establish services and pathways locally, develop a clearer understanding of the experiences of people who use services, their families and their carers, sharing learning with national partners such as the Department of Health and Social Care, further develop our insight to evolve our data offer to key stakeholders to inform our understanding and reporting of the impact of COVID on a regular basis. Understanding local population needs, including cultural differences, is especially important. The quality of existing relationships between local providers played a major role in the coordination and delivery of joined-up health and social care services that met needs of local populations. An increased focus on shared planning and system-wide governance. Staff across health and social care worked above and beyond their roles. We spoke to dedicated, passionate staff committed to supporting everyone. There was a range of initiatives to ensure the safety and well-being of staff working both on the front line and in support services. The move to a digital working accelerated and impacted on access to services, and more generally digital solutions supported data sharing and communication between us all. Next slide, please. Our early thinking on systems. Through the Health and Care Bill, CQC could have a new role assessing how well health and care systems work together across an integrated care system. Assessments will provide independent assurance to the public of how well health and social care partners within an ICS area are working together to deliver high quality care to people. This will support system accountability and align with NHS and I oversight of ICSs, encouraging the shift towards more integrated services and improved outcomes. We are working with government and other stakeholders to develop our approach to good system working, built on what matters to people using services. Local authority assurance. Our new role will give us a new duty to ensure appropriate levels of oversight on the provision and commissioning of social care, with an initial focus on improving the quality, timeliness and accessibility of adult social care data. Establish an assurance framework to help improve the outcomes and experience of people and families in accessing high quality care and support wherever they live, and to be confident that funding is spent as intended to improve adult social care outcomes. Assess local authorities' delivery of their adult social care duties to be developed over time as the final element of the assurance framework. Give Secretary of State powers to intervene and provide support where there is a risk of LAs failing to meet these duties. Ensure people's experience of care will drive that activity. Assessments will lead to published information, the detail of which is still being worked through. Mechanisms would be developed between CQC and partners for escalating concerns and arranging improvement support. Next slide, please, Howard. Thank you. On the theme of learning from good practice, committed leadership. Key role of leaders who are enthusiastic and committed to equality and human rights. Principles into action. Equality and human rights is a thread through your organisational values to leadership behaviours and actions to frontline staff and their work. To develop an open and inclusive culture and work to tackle specific workforce inequalities. Make space to innovate and think about equality and human rights as a solution. Planning and delivering change to improve care through equality and human rights. Listening carefully life outside services and to people's aspirations. Reach out to others and be prepared to have a mirror shone on your work. Be honest, take positive risks, and tackle difficult problems. Learn from mistakes, always look for the next thing to work on. Next slide, please. These profiles bring together data to give an indication of how different services work together. We use national data to build a set of cross-sector indicators. The profiles show how well the system in each area performs against them. Now, there is something there that you can scan, but I'm not sure it's going to work on a slide. So what I'll do is I will undertake to send Howard a link to the area profiles on our website, because they bring together all the data we hold on every provider in the country, and you can extrapolate it how you like. Next slide, please. With a focus on equality and human rights, in driving improvement, it's not enough to create an improvement plan. Staff need to be engaged and motivated to drive it. There needs to be a focus on equality and diversity, so all staff are engaged. Engage people in owning their vision for their service. Empower staff to lead quality initiatives. Have a no-blame culture and celebrate success. Consistent oversight of the organisation. Visible and approachable leaders give staff confidence. Good leadership builds strong teams and fosters teamwork throughout an organisation. Good leaders stay in touch with their frontline staff and with regular communication. CQC inspections support improvement. Our reports can help give structure to improvement work. They can give a rigour and a discipline. And I'm happy to give an example if people are interested of where we have recently driven improvement on a provider who has gone from inadequate to outstanding. Our reports provide examples of good practice to others, and regular engagement with inspectors promotes understanding. Next slide, please. Almost done. Actually, I've just done that one. No, sorry, I haven't. Sorry. So a strategic plan for quality improvement is supported by unwavering commitment from senior leaders. Time and time again, we see services fail because the leadership has changed, and it can happen dramatically and quickly. Training for leaders in how they improve the quality within their service, whether that's an individual care home or whether that's a group of care homes. Leaders model appropriate improvement-focused leadership behaviours and shifts from a top-down model to a coaching model. Visible and hands-on leadership. Next slide, which is the last one. So these are all the reports that we have recently published. Thematic review of the use of restraint, prolonged seclusion and segregation for people with mental health problems, learning disabilities and autism. Medicines in health and adult social care, learning from risks and good practice for better outcomes. That report shows what we found about the common areas of risk when using medicines across health and social care in England. And we wanted to encourage improvement by sharing what we had found through our regulatory work. There's a whole raft of reports on our website, and I would urge you to go and have a look. So that's me. I think we're going to open now for some questions.
Teresa, before you do that, do you want to quickly give us the oversight of, you said you've got an example of improvement?
Okay, so I've got to be careful that I don't identify the provider because we haven't published a report yet, but so I'll have to be slightly vague, but I attended an inspection because we were concerned about the safeguarding approach within the provision, and it was a very specialist service, and we found the provider to be inadequate at every level of the organisation, from their systems and processes to their governance to their leadership, and it was a very difficult set of conversations that we held with that particular provider. They were very defensive, quite aggressive at times because they didn't want to hear what we were telling them. And in working with them through the last year and a bit, you know, eventually they realised that actually what was missing were key members of staff within their organisation that could drive the improvement that we were seeking. And they did that, and they have completely turned around from being inadequate on safeguarding, and I don't get to say this very often, to verging on outstanding, which is astonishing in just over 12 months. And it shows absolutely that regulation can drive improvement, but providers have to listen to what they're being told about what is needed. And I think that where they do listen, and where they have good leadership, and if they don't have the good leadership, they get it in, you know, they buy it in, whether that's temporary or whether that's permanent. But you can, and it's a really good example, and once everything's published and everything, I can be a lot more open about which provider it is. But you know, I have been inspired by the conversations I've had with that particular provider, and honestly, I don't get to say that ever, really. So so yeah, and there'll be more coming out about it in the next few months, because I'm actually going to use it as an example of what good looks like. So I'm starting to write what good looks like for us as an organisation and how we approach safeguarding, but we will then be developing what good looks like for providers. So, you know, this is our baseline expectation of what we expect you to do, and I'm going to be using this provider as an example of what good to outstanding looks like.
Excellent. Thank you, Teresa.